back to the Movement Professional Podcast. Good to see you again, Dr. Richards.
Good to be back, Dr. Leib. Missed it here, but always good to be back on this lovely Friday.
Absolutely. Good. I think we're always sharper on Fridays. So we'll see how we are today. So today we're going to discuss shoulder pain and, talk from our experience as clinicians, any history we might have had with our own shoulders. And really, I think one of the best conversations to have is, what are the movements that tend to, either provoke shoulder pain or, you have to limit yourself when you have shoulder pain, and how do we as therapists get people back to doing those things that they want to do? I think that ultimately will be probably the most valuable piece of information there. But I'll start, your way. When you have somebody who comes in and they're complaining of shoulder pain, what's the first thing you want to try to get out of the patient, try to find out so that you know which direction to go with your treatment?
I think the first part is just trying to hear their story and understanding, like we always talk about, I think you always mention like the with what, but kind of understanding what the course of their shoulder pain has been, whether that's a new injury to something specific or whether that's something that kind of popped up out of nowhere, or if this is something that's been going on and off for years on end. And, typically from there, it does come down to the with what and understanding if they're having pain in a certain movement. We're able to, just like you do, I think, in your head, like dissect what goes into those specific movements. So I think pressing is one that I hear a lot. And after hearing their story, we'd like to look at, or I like to look at, really simple, just range of motion tests, whether that's reaching behind your back, trying to touch both your hands together. So one arm is going over your head, behind your back, the other is going behind your back and up your back. And having people just assess their limitations there, or any differences or things that they feel are significant side to side. But typically, I think I kind of break it down with people that are either having pain in the front of their shoulder versus more so in the back. And that kind of helps me tease out whether, I think front of the shoulder, like typically referred to as more impingement type symptoms, versus back, you might think a little bit more rotator cuff related, with exceptions, but that's kind of generally where I'm starting. Is it in the front and the back? What are they having pain with? And then assessing where they're limited. So whether that's active range, like having them reach behind the back, but also putting them on the table when it's warranted and being able to see, okay, where are you limited? What motions do you struggle with? Are there any points that actually bring on their pain? And also looking really specifically at, as we go through things, watching them do a version of potentially the provocative movement, so that we can get a sense of what's actually going on, whether this is potentially more of a biomechanics issue potentially, or if there's some things we can clean up from a form standpoint, or potentially if it's a capacity issue more so, where we need to actually build some things up surrounding the area to make this person more capable of performing this movement. So that's kind of where I start with people. And I know there's probably some similarities to you and what you do, but what is your process when someone comes in?
Well, I think, what you mentioned there is like key is that you're finding categories, right? Like, you might categorize the front of the shoulder, the back of the shoulder. I tend to look for categorization wherever I can find it. So it kind of helps me dwindle things down to, okay, like this is the low hanging fruit, but I'm going to, change my treatment process towards this focus because I see someone is in this category. So, outside of the location of pain, the other thing that I'll tend to look for is something painful at an end range? Like if we're reaching overhead, is the pain coming on at the very end of that normal range of motion, or does it happen somewhere in between? So in the midpoint, I think that's an important distinction, because usually the treatment becomes quite different depending on, where the provocative symptom comes. So looking at it as an end range symptom is the midpoint symptom. Oftentimes that's called a painful arc with the shoulder if it sort of hurts in the middle. But then as you get farther through that range of motion. It actually gets better as you get higher. So I'm looking for that. And then as you mentioned, the differences in range of motion. So I like broadly the categorization of, is somebody having pain when their arm is moving away from the body, or is it more when it's kind of moving towards the body and behind the body, right? So you have the scratch your back test, which is a little bit more external rotation when your arm is going overhead and then behind the head. And then there's behind the back where you're reaching back into extension, internal rotation. So a lot of times figuring out which one of those two is more provocative is another type of categorization that we can, again, we don't make too many assumptions right away, but we can then follow that farther and say that there's usually different things we have to focus on when somebody's having more issue going behind the back than overhead and behind the head. So looking for as many of those broad categorizations as I can first will give you a sense of, okay, what direction do we want to go? Do we want to work on mobility more first, or do we want to focus more on maybe control proximally? So center control, core control, control around the shoulder blades and rib cage. And if we could put that into a different position and then ask the person to go through their provocative action again, does it actually change the symptom? Does it make it better because we've organized the center a little bit more first? So a lot of times with that midpoint type of pain, changing the positioning and the focus of the stuff that's more central or proximal can have a change to that midpoint or painful arc symptom. And it can become very specific to the person, right? So it's not like one exercise, one cue fixes all. It would be trying to get very specific to that person's symptom in the moment and say, okay, what are the best cues, usually starting from the center, then going outward, that can change the symptom for the best. So it becomes a very person-specific assessment around the symptom, but the symptom really becomes very important. It's probably the most important part of the assessment to me, is seeing how that changes with different cues.
Are you typically like testing, retesting things within a session, or how do you kind of structure that? Like if you find a provocative movement at the beginning of session, are you kind of coming back to that again throughout, or does that vary person to person?
Less so than I used to. I would say, like I used to do a lot of stuff where I would use manual therapy, and especially with range of motion, or finding the onset of pain, how deep into the range of motion. I would do some type of mobilization, and then I'd retest the same thing that was provoking the symptom. I don't do that quite as much, but I find myself trying to actually put a person into a slightly different position and have them do the exact same thing they just did, and see if that adjustment somewhere else in the body changed the symptom in that moment. So as opposed to doing some separate exercise and then having somebody do the exact same thing they did, I'm going to actually just continue the thing that might have initially provoked the symptom and keep going with that, right? So like very commonly, if it's a right shoulder pain, I may have somebody focus on their left abs, in a variety of different ways, and then have them reach in the same way, maybe behind their back, if that was what was provocative. And is there a difference between having the right abs activated and not having the right abs activated? So the assessment is more like in the moment than do something and then retest. But every now and then the retest will happen sometimes naturally, where you'll have somebody do something and then they get up and they just sort of, oh, it feels better, type of thing. But I think I used to put too much stock into that in my assessment, where because you realize how actually easy it is to change symptoms. So, and it's you're not doing anything that great when you're doing that, and it's just as easy for them to go back to where they were. So it's a little bit of I think a false lead when you start seeking that stuff out a little too much. But I think it becomes a little bit more valuable when you can show somebody just a really quick cue. It's like, literally in this moment, if you do that and you do the exact same thing, your shoulder pain will be less. That could be a strategy that you use right now, starting at this moment, that makes your shoulder pain better. And then you start to have people connect the dots to, okay, this isn't just a shoulder issue. This is always a full body issue. And we're sharing the load in our body in different ways. We just have to figure out what's the optimal way that takes the symptom and brings it down. So again, making the pain that someone comes in with not something to eliminate, but actually something to use, to be curious about, So the idea they could figure out a different relationship in their body. That's neither right nor wrong. It's just a thing that's helpful. But you and I have these patterns that we might go to say like, okay, let's start here because we've seen this be successful in the past, and it's based on some type of biomechanical relationship that we've learned. But ultimately, if it doesn't work, then we try other things, right? But the idea is to actually explore the symptom and see what makes it better in the moment.
Mm-hmm. Yeah, no, I couldn't agree more. And I think there is some, like, if anyone listening were to just test a limited movement and then go like on a 10-minute power walk, they can probably come back and that
Right.
movement is going to be better.
Yeah.
So it's like the value of that is not necessarily like that improving is not necessarily specific to potentially what you did for those 10 minutes.
Right.
It's just things actually start moving. But I was just curious about that. And so kind of going back to your classifications, you talked about starting proximally. What's that look like for you? I know you just mentioned like someone's having a certain type of shoulder pain, you might cue some different type of proximal positioning. Like I know you said left abs, right shoulder pain. Like what's your thought process there and kind of where are you going with that?
So first I'll start like without any type of adjustment, right versus left, just having a sense of where is somebody's head related to their rib cage, related to their pelvis, right? So even if we're talking about a shoulder or an ankle or a toe, like we can always start with that idea of where's your head relative to your rib cage, relative to your pelvis. And then more specifically, if we were say using some type of flat plane like a wall or the ground, you can say like, where's the back of your head compared to the space between your shoulder blades, which would be, terms could be dorsal rostral area, or I just think of it as like the interscapular region, right between the shoulder blades. It's also your thoracic spine, or a part of your thoracic spine. And then the back of the belt, which would be like the base of the sacrum. So those three areas, where are they in relation to each other? And a lot of times what we'll find is the heads might be way forward, the pelvis may be behind, the space between the shoulder blades, but there's some type of relationship that's often not stacked when somebody is doing an exercise, or when they go to move in a provocative way, there's a movement that also happens at either the head, the rib cage, or the pelvis, along with the movement of the shoulder. So we're just trying to get control there first, where it's like, let's keep this in one standard position and then ask you to move from the shoulder and see what happens. It's not always going to decrease the symptom, but it may, but it also will tend to totally change the movement. So you tend to see less range of motion than what someone thought they had when you start to control the middle. And oftentimes that less range of motion may also couple with, okay, it doesn't hurt when I only go this far, but I can't reach to where I normally would want to reach to. So then it starts to have now we have the conversation about, okay, well, that's actually the end of your shoulder range of motion. Everything else you were doing was coming from a combination of movements from other joints in your body or compensations. So now the goal would be, okay, let's improve the actual shoulder range of motion independent from all of these other compensations. That becomes the therapy from a starting position. And that's without us talking about shifting one way or the other. But could we just start with that idea of we're going to move the shoulder while the head, rib cage, and pelvis stay in a more standard alignment, so that we know that the movement that we're trying to do is coming from the shoulder more specifically.
Yeah, I feel like I use a similar methodology, and sometimes like the proximal positioning. Do you do any drills for that, or are you just kind of like cueing someone on that stack and then going into that movement? So like that behind the back reach, for instance.
Yeah, so I mean, I'll try to, instead of doing drills for it, I'll try to use props and feedback and constraints as much as I can.
Yeah.
But then I'll let those constraints be. So if I'm using a wall, for instance, or the ground to give reference for that, I'll let that start a conversation of, I would like you to not have to use this constraint. So that's going to be a different, perception, right? So if you don't have the constraint, now we have to have some awareness of where your head is, maybe some muscle contraction in your body that is a reference for position. We're going to have to connect those dots eventually. But I think that the first thing to do is really use a constraint. So, because that could become an exercise that somebody is able to do at home easily, but it starts to show the relationship that you're trying to go for better. And then the progression is really not needing as much of some type of external constraint to hold that position, but have more of the body awareness to be able to do it yourself. But it starts to at least give the pathway forward to the patient. You know, it's like where right now you're going to need these extra constraints, but our goal is to have more awareness of this positioning as you go. And then again, the symptom becomes something to be curious about. So how do I know that I'm in the right position? Well, it doesn't have to be right. It just has to be better. Like it has to just make your symptom better, right? So there'll be certain feelings that you get from that, but the number one feeling should be like, if we're doing this right, and if the constraint that we're using helps, then when we take the constraint away, any posture that you do that makes the symptom better is closer to what we're going for. So I try to connect it conceptually as opposed to making it about specific drills.
Yeah.
But the constraints become the drills, you know, if you will. Like, right, well, you do things on the ground, not necessarily because, you know, we're trying to isolate specific muscles, but the ground changes the relationship to gravity. So there might be more or less resistance in the limb you're trying to move. But then there's also this idea of, okay, well, I don't have to think so much about my posture because gravity in the flat plane of the surface you're on is sort of putting you right into the posture that we're trying to go for. And then we can add on to that by changing the position.
Yeah, I think along with that, like I would say I'm similar, but then I also think I end up like teaching, I feel like a lot of the proximal positioning and looking at it through some type of closed chain assessment, whether that's like a high plank shoulder tap, a plank, push up variation and I know we work with slightly different populations. But I find like that's kind of where I end up trying to bake that in. And then also being able to understand like, okay, what's the upper limit that someone's able to handle safely in a closed chain or like hand on the ground position, whether that's a plank, side plank, whatever it is, to kind of be able to see how they're able to articulate their shoulder along the rib cage, scapula along the rib cage, and ultimately look at body control there to potentially see where things are moving, where things might not be, and understand what their movement strategy is going to be.
And I love that point, because I think that actually can give more context to the idea of working with any injury. That, all right, so we're talking about a shoulder here, but any injury has this categorization of like, what's the stuff that we have to be really careful with, the stuff that people can't do well or are provoking the symptom. We really want to know that, but we don't necessarily want to make all of our treatment about that, right? So, you know, a lot of my treatments nowadays are a combination. They're sort of like an aside to training, right? So if somebody comes in and we're working on shoulder, it depends on, you know, how long I've been seeing them for, but I will likely also put them in some type of general fitness routine that is able to assess all of those relationships, but not make it specific to the shoulder. So I want to see, you know, like hopefully some type of general pressing movement, some type of general pulling movement, and then just see like how do they hold weight while they're doing lower body stuff, right? So a lot of the patternings then just come out in that process, but they might be a lot less threatening and certainly less provocative to a symptom for the patient, right? So there's so much to be gained from just like a general fitness assessment. And to me, that should be involved in almost every rehab process, if possible, that you're not just working on isolating the joint that somebody's complaining about, but that you actually have a full body movement practice that is being done. So you know, the individual can realize what they still can do well, but you as the clinician are also assessing all of the different nuances of their compensations that might not be painful, but there's just ways that they're working around different full body exercises. And the two come together quite nicely, where fitness is still being built because they're doing a lot with their body that's not provocative. You're getting a nice assessment of like how they just move overall that may be related to the shoulder. But then you know, you have some time that you're working more specifically about it, and oftentimes like the two worlds come together.
I always think of that in terms of like, even if it's specific to an injury, like if someone is coming in for specifically PT in our case, and like we kind of have to center around that to a certain extent, then it's still about like finding what are their quote unquote green light movements that we can actually train really hard, that are to some degree related to what they're experiencing, and can move the needle in the right direction, and also like so that they can continue to push fitness forward in some way, so they don't let a like orthopedic issue like shoulder pain become a metabolic issue where now they're out of shape and less fit than they were previously. And I think it's just like a scale of the same thing we're saying, whether that's someone's coming in for fitness initially and you're kind of potentially training around something, or they're coming in directly for PT, you're still able to find what these green light movements are, and then what are more so some things that you need to protect against and really focus on more like gradual exposure towards, with that person's pain to just varying degrees, but you're still giving them a training stimulus in some way.
Absolutely. Yeah, what I've been doing a lot lately is, we talked in other episodes about how to build a general circuit that is full body. So like the squat, push, hinge, pull, core, and the different variations we had on that mentality that creates a full body type of exercise routine. So if there is some part of the body that is more symptomatic, or we have to be more careful with, I still try to keep some movement that I would want them to do if they didn't have symptoms in the continuum of that circuit. So it doesn't feel like we have to do separate stuff or too much separate stuff for the shoulder if we're working on the shoulder, or the knee if we're working on the knee. So for example, if we do a squat, and the squat's not an issue with somebody's shoulder, but then we get to the push, and that's where we have to be more careful with. We find the push that would be least provocative, but we might even think about at the press that would be more provocative, but using assistance for it. So for example, an overhead press a lot of times is like end game rehab for shoulders, right? Like if you can get somebody to press load overhead, their shoulder's probably doing a lot better for a lot of shoulder conditions. But using a band where the band actually assists the pattern, the shape of the press, but now the band is actually making it easier because it's guiding the arm up, but you still have a little bit of resistance on the way down, but the resistance is in a different direction. It starts to that is your press right now, right? So it gets that into someone's head that we're still following this curriculum of whole body fitness, but just with that press today, we're adding a band because the band makes it easy enough. It makes it not provocative, but you're still working on the pattern. And then it makes it easier to look at it as a continuum where it's like, okay, now we're just going to do that pattern without the assistance of the band, just with your own body weight or with just gravity, right? Can you do that? Now we add a 2-pound weight. Now we add a 5-pound weight, right? And that might not be the only thing we do for pressing, but that's going to be how we kind of work on getting to their end game. And that's why I like to think of like these fitness movements a lot of times become the end game thought process of how do you know that you're all the way better? Well, you're able to do all the things that you want to do. And for a lot of people now, that is harder fitness movements, right? For some people, it might be work related, it might be sport related, but for a lot of people, the gym becomes your way of testing their limits, right? And you can do it in a more controlled manner. So it's identifying those things. So I think a lot of times an overhead press becomes the thing that is end game for a lot of people with shoulder issues. And it becomes the thing that they're often told not to do, or they're most fearful of doing. So having right away or very early on some type of process where, okay, you're in the press right now, but we're just making it easier for you.
Yeah.
But now, like week 2, well, now we've made it somewhat harder, right? It's still not looking like you're lifting weights overhead, but we have a press pattern for you. And I've seen that just progress people so much quicker than having some type of timetable in your head where it's like, okay, I'm not going to press overhead until we are, like 6 months out or something like that, where it's like, you can start with a band pretty much right away. And it actually becomes a therapeutic exercise. People tend to feel better with it because they're being guided and assisted into it. And then the horizontal pressing type motion might be for some symptoms, much easier to do. So you can add more load to that. And you can even then take the incline decline bench and make that a continuum, right? So a lot of times there's certain presentations where the decline, you can do way more load early on than you can do the incline. And then there's some presentations where it's the opposite. So trying to, again, categorize that as like, okay, this person is much more biased towards being able to decline press. And we can talk about why that might be, right? Somebody who does better with a little bit more extension in the shoulder, that's closer to decline, right? Like your shoulder has to be in a little bit more extension as opposed to more flexion when you press, right? So that would be part of the continuum. What are they better going towards extension, or are they better going towards flexion? But all of that could be a matter of degree with just how much you incline or decline a bench. And ultimately the press is the same thing. Your body would just be changing relative. Are you standing? Are you lying on your back? And that's how we can kind of take the press through a continuum. So I've seen that being quite useful, because that becomes, for most people, like one of the most threatening thing with shoulder problems is being able to push load.
Yeah. I think like the overarching theme to that I end up thinking about a lot is like, what is the closest variation I can give this person in front of me to what they're having trouble with, that like they can do well and feel good with. And I think that's where it's like that overhead press, the band assist might be where you start with that, or it might be starting with an incline bench variation or a landmine press or something like that. Like some variation where they can still work hard, feel good doing it, but it's close to what they want to do, as opposed to being like, oh, you have shoulder pain, we're going to do all these band exercise, we'll come back to your press in 6 weeks and like hope it's better, as opposed to kind of training right on that edge at all times and keeping them safe, but like having a really good assessment of where they're at.
Yeah, and it doesn't even have to be like the edge of pain. It could just be, no, you're keeping them close to the thing that they have an issue with, right? And I think that sometimes the best thing that we do as clinicians is just connect those dots for people. Like they don't have the same way of looking at progressions and regressions that we do. So trying to get them on board with that as an idea, where it's like, like it's not hard to make this just a little bit easier to where you feel safe with it. I'm not telling you it's safe. You actually will feel more safe with it. We just have to find that place for you. And I think a lot of times patients are surprised when you ask them to do something that is within that continuum, how much they can do, right? And then there's just actually a little bit that hurts, right? Like there's just a little bit of a range of motion that hurts. But if we work below it, we work above it, we're good. Or if we assist it enough, or just lighten the load enough, they're good, right? So it's just finding all of the stuff that can be done. I think with the shoulder, that's probably the most common area that you see. It's very specific arcs that are very painful for people, but there's a whole gauntlet of motion, right, that is still available that's not painful, because the shoulder is the most mobile joint in the body. So it's about controlling all that motion. But when there's pain involved, it's also about showing people specifically what does hurt, so that it doesn't, the narrative in the head isn't, well, my shoulder hurts broadly. It hurts with everything. Like I haven't been able to do what I wanted to do for a while. It's like, okay, like let's pinpoint like where within the motion exactly it hurts, and see that change over time, right? See that get smaller, not necessarily go away 100%, but just get progressively smaller. So they're really in the process of seeing things change. Okay, oh, I could still do more than I thought. And I think that's really important, is connecting those dots.
Yeah, completely agree. I think that the other thing I find myself talking to people a lot about is you touched on earlier, like I think what success could look like for someone, and like pressing overhead is something often with the shoulder. I think I talk a lot about like, we obviously want to see pain get better, but we also want to improve preparedness to the point where you're able to actually tolerate a lot more than you are right now.
Yes.
Without things, one, getting worse, but also two, I mean, ideally feeling better. But like pain, just chasing pain, I think can become just like a dog chasing its tail, where you end up not making a whole lot of progress. So I try to kind of make that clear with people off the bat that, yeah, like we care about your pain and we want to start to see it come down, but we also care a lot about improving your ability to actually do all these things that we found today that are kind of difficult for you, but that are related to what we're actually seeing with you at the shoulder. I think that's another part of connecting the dots for people too.
Yeah, 100%. Yeah, I think if you can turn a pain conversation into an endurance conversation, I think that's useful, like connecting those dots. And so like, what I mean by that is, if somebody is their major complaint is pain, but what they would describe is the pain starts after a certain amount of time doing a thing, right? So it doesn't hurt every time I move this way, but after I do a full workout of kettlebell snatches or pressing, my shoulder hurts. So then we now have, okay, your pain becomes your signal that your body is doing maybe too much of that thing, but it doesn't mean that that thing in itself is bad. So then it becomes like looking at the symptom as, and it's the endpoint of what your capacity is from an endurance standpoint more than it is, okay, I should never do that type of movement. And I think, again, a lot of times that needs to be talked out, right? Like it's not intuitive for individuals that are having pain. It's just like, okay, it hurts when I exercise it in this way, as opposed to it being, it hurts when I exercise this much doing that, right? So making it about this much or making it an endurance thing is just like, well, what would happen if you were running for 5 miles and it's, it hurts when you run 5 miles. What you would do is you would maybe not run 5 miles, you run 2 miles for now, but you could still run. And then we gradually build up your endurance so that you could run longer without pain. So trying to make the symptom just part of the overall process of what somebody's fitness is, I think is an important thing to do, right? Is to not make it something separate that, okay, well, I'm in pain now, so now I got to shut it down. But it's like, no, that was just indicating that you did more than you were ready for. And I think with the shoulder, a lot of times you'll see that with, different types of workouts, especially boot camp style workouts or circuit style workouts, where there's a lot of reps being done and the aftermath is the shoulder hurts. And then it becomes, okay, how do we make that a little bit more objective? How do we break that down to figure out what is like the capacity that you're ready for, and how do we modify that if you're in a group setting or something like that?
Yeah, and it sounds like too the goal of what you're saying too in the boot camp setting is like you always want to keep someone as much in the game as you possibly can, and I think that applies to every injury here.
Absolutely. Yeah. So I think the other topic that I think is important is, and I just had this as a case study recently, is just looking at the difference between traumatic injuries to the shoulder, and you could put any joint here, and then insidious onset injury. So insidious onset would be sort of like unknown origin. A pain is coming gradually over time, but doesn't really have like a good definitive mechanism that you could point to and say, like, this is when I hurt myself. Where traumatic injuries, which, you can have a moment where I just had a patient or a client who was squatting and the bar missed the hook on the squat rack, went to catch it, and the weight kind of took his shoulder into a torque that created pain and then a rotator cuff tear, right? So looking at those traumatic moments, I think the whole treatment process and the thought process around it is very different than if you have somebody whose pain kind of comes on gradually over time. And I even like to separate out the idea of like, when something is traumatic, it's an injury. If something is insidious, it's pain, right? Like we actually can't point to an injury, like a tissue injury in general. We can look back and get x-rays and MRIs and find some type of damage or structural abnormality in the body, but that doesn't necessarily even link it to the pain.
Yeah.
Right. And we've had that discussion ad nauseum in other podcasts. But so that mechanism of injury of complaint is so key. So if there's trauma, a lot of times surgery is a really good idea in those cases if the trauma was bad enough and it caused a rupture of something that right before the trauma wasn't there. Right? It makes sense that it might not even be a pain issue after like the initial problem with it. It might just be like, okay, now I lost function in this shoulder that I had before that trauma that I can point to. And when those things happen, it also becomes a little bit more predictable of what you would do with it, right? So you would imagine that the healing process of the tissue is now a little bit more predictable, something you can follow from a physiological standpoint, where when there's an insidious onset of pain, there's a lot more variables that have to be taken into account there. And I think that's where it becomes very much person specific about what feels safe for them in any one moment.
Right. No, I think that's such a huge point, and it applies to, like you said, all over the body. But yeah, I just had a couple of people recently, someone got like knocked off his electric scooter in the city like twice actually in like 2 weeks. And like flipped over his handlebars, like AC joint, grade 3 like sprain. Versus we also see a lot of people that come in, especially like we see a lot of lifters that come in and they've had pain for better part of a couple of years on and off, and it's just tended to get worse recently. Right. And I think that language of injury versus pain is so key. And even in the case of injury, I think it almost becomes actually easier to talk about pain.
Yes.
Because like you mentioned, like you have an idea of the actual tissue healing process, and there's potentially less factors at play.
Yeah, and I think like we crave certainty a lot of times and one of the most challenging things with insidious pain or chronic pain is oftentimes there's no feeling of certainty, and we're searching for it. We're searching for that diagnosis that's going to say like, this is the problem, this is what you do about it. But the thing is, it's like that doesn't exist with chronic pain. It becomes a process, and there's no way around that, right? Like it's a process that's something you continuously have to work with and manage. There's no thing that you can look within the body after a certain point in time and say like, okay, that's the thing that's broken. We just need to go through a process of fixing it. But with trauma, like that is more consistent of what you can find, right? Like, so it's oftentimes more comfortable for the individual to say, yeah, this sucks. This is just going to change my life. But I at least have a certainty of what happened, right? I know where I was. I experienced it happening. And I think it can be much more acute early on and maybe even more painful of the beginning of it. But in the long run, I think a lot of times it's easier to deal with and you have better results, where the chronic stuff just becomes this process if you don't get on top of it. And you really do have to have a multi-factor or a collaborative approach of working with it a lot of times. And you have to appreciate your thoughts around it, what you're feeling is safe, and even history around it. So yeah, and that can go for any conversation about pain. Is the mechanism plays such a role. But I do think it's misunderstood, because oftentimes when somebody's feeling pain, they don't think of it from that perspective. It's just what's damaged in me.
Yeah. And I think that's where like some of the pain research that's come out, like I know Larimer Mosley has a whole resource or website of resources kind of talking about what pain actually is, and that pain is more so potentially like a danger signal than an actual assessment of tissue damage. And that's what is rooted in evidence now. And I think that's changed over the past 60, 70 years,
right?
What pain actually tells us. But we've talked about that a lot on here before, I know.
Yeah, absolutely. Any recent case studies that you have that have been of interest with the shoulder? Things that you found quite useful that maybe were new and that you're starting to use more often?
I think like an overarching theme that and this is going to sound almost this isn't going to sound very educated, but like with any injury, like, but I'm thinking about the shoulder, like I always think about how can I actually get the shoulder hot and get things working pretty hard, in a like safer way. So like whether that's doing some type of like rotator cuff series or something where I'm challenging them through still through like full protraction, retraction, and upward rotation, but getting to the point where like all they can really think about is like the back of their shoulders just burning, or get them to a point where like on a press or a row or a lat pull down, like they just feel their lat and it's cooked, and like finding the variations for them, I think is the overarching theme. But in terms of case studies recently, I mean, I did have someone who had a couple scooter accidents with that AC joint sprain. And that was interesting just because we ended up making a fair amount of progress in like 3 weeks. And then actually almost the exact same accident happened again. Same injury, it got worse. And yeah, I think we used a lot of the similar themes, but what I ended up having success with there, and this is, I feel like most people I've worked with AC joint type issues, is being able to find a way to kind of load them into some deeper shoulder extension, whether that's like a close grip press or like a deficit push up. That's tended to feel a lot better for people and able to actually like get them to move their scaps and shoulders a little bit more than potentially going the other way and like loading them into a more protracted state, which I mean makes sense with the idea of an AC joint injury.
Yeah.
But yeah, I thought that's been interesting for me.
And that would be interesting for what we're talking about with like this sort of press continuum. Like, so that individual sounds like might do better with more of like a decline type of idea, because it's, you know, things are moving down into extension first, but then you can even get deeper with the range of motion there. Likely starting, you know, with the bar or whatever you're using, going lower towards the abdomen as opposed to higher towards the shoulder first. But I think that, yeah, it's interesting stuff there. And again, like there's all these different diagnoses that you hear that are kind of connected to the structures that are involved. Well, if somebody fell on the area, that's going to be a big part of, you know, what the problem is, what you have to work around. And sometimes those traumas, there's a specific surgery that, you know, is useful in those moments. But if there's not, and there's just like the direct trauma there, well, for you, it's oftentimes in that moment, you're like, all right, how do I let the natural healing process take hold, but still get people to move in ways that aren't the symptom, right? And it's not just for, you know, keeping people moving, but it really, if we think about it from like a physics and pressure standpoint, getting an area hot that wasn't the area that was deemed unsafe starts to literally move pressure around the body. So if you're having pressure and the heat is up in the AC joint, which should be the top of the shoulder, and you start working other parts of the body and getting some heat to that, like literally pressure is moving from there and being dispersed better through the body, right? So there's a bunch of neurochemical relationships that happen there that actually decrease pain. But it makes absolute sense what you're saying there. It's just how many ways can we get people feeling their body in other places that weren't the area of pain, and that itself becomes the pain reliever. Well, the better you are at doing that, the better your fitness is as well, right? Because you have more access to more of your body, to creating more force in your muscles, right? And then I was just researching a talk I did on pain and how connected the fitness response is, and everything that goes into the adaptations around fitness, and the pain modulation response, which is basically is another way of saying like, how quickly will one feel pain with an action, right, compared to another person. So very much in parallel to how fit an individual is in other ways, right? So the difference between exercise being painful for somebody and pain relieving is oftentimes very much connected to their overall fitness. So all of that, I think, is, like plays a huge role, and it's, it can kind of just manifest as like, let's just make something hot that isn't your pain.
Any recent case studies for you?
I would say just I'll give broad case studies, and I was already alluding to it, where it hasn't been with acute injuries, but people who have had just chronic rotator cuff stuff, and even the way that it manifests, like they're super fit in every other way, but their path for reaching overhead is something that we would say it's not straight, right? Like the elbow has to kick out. They have to find a way around the symptom or the impingement because they've had rotator cuff surgeries in the past and likely tears in certain rotator cuff muscles. But taking people through that press continuum, I think has been just such a game changer. And I've been able to really tie it into fitness, so it doesn't have to be like separate physical therapy, and get people to not really have to take a step back from fitness in any way, but keep in mind their limitations where they can't, go as heavy with. And it's been cool to see how a band press turns into a 10-pound overhead press, but then somebody's, horizontal press or like floor press becomes 25 pounds when it was 10 pounds at first.
Yeah.
Right. And, the symptoms were the guide throughout that whole process, but also you see that strength and symptoms kind of go hand in hand if you're gradual enough with it. Is that, like if we would have gone too heavy too soon, there wouldn't have been a lot of strength there, but there also might have been pain that got in the way of being able to produce more force to move on to the next thing. So you could take it gradually enough, just like you would in the absence of pain, you'd see physiological change that would create more strength. Well, you're sort of seeing that now, even in non-optimal patterns. So I think that's been really cool. Like where I might not have had anybody who didn't have like a nice clean angle of press overhead, try to press overhead. But now using the right assistance or resistance, I'm exploring that a little bit more and seeing progress, but it doesn't mean that the press looks beautiful by any means. It's just that the strength, even within that limitation and compensation, is improving. So therefore overall function is improving. So I've seen that with a couple people, and it's been kind of a cool process to work on, but it's not possible to do that, I don't think, unless you are also working the rest of the body. Practically, just like, I don't think anyone's going to want to stay with it that long unless it's connected to full body training. But it's been kind of cool to see that. Oh, okay. Like I'm curious to see how far we can take it, even with the obvious structural limitations.
Yeah, I think that builds so much more internal resilience too within that person, whether they know or not. Like it's like, oh, like this, something kind of looks off here, but I feel fine. And I think that applies to everything. Like movement doesn't need to be perfect, but you need to be capable enough in the movement you're doing to actually just be prepared to do it. Like you could have the perfect looking press overhead, but if your body isn't actually prepared for it, like you're still going to have trouble. And that's where I think it's building up people's capacity becomes such a huge part of this, almost more so I think at times, or a lot of time, than like the biomechanical piece itself.
Yeah, and the last point I'll make on that is like, we talk about like building up capacity, and there's often, people that just need to build up capacity everywhere. They're starting from low fitness, but then there's also like people that have really high fitness and they've already gotten quite good at working around their symptoms. But they're quite sure that they should never work into that pattern that has been problematic. So I've had a couple of people where they're quite fit and they're very good at actually working around their symptom, but they've given enough faith in me to have them work towards the thing that they were fearful of, and to see that progress has been really cool. And it's certainly easier with people that are already starting with that curiosity or have been willing to work around symptoms, but actually now kind of going into some of the stuff that for years has been limited and just been in their own heads off limits, and see how that can improve has been a cool process.
Absolutely.
All right, I think we touched on some good stuff here. Like anytime we talk about pain in any joint, there's going to be a lot of common threads throughout the body. What makes the shoulder unique, I think, is this, the amount of mobility that is offered there. It's the most mobile joint in the body. So there is a lot of room for assessment and, to find out what specifically is provoking the symptom. But there's also a lot of need for stability centrally to change the mechanics at the shoulder. And sometimes that gets tough to deal with, right? There's just so many moving parts that it's hard to see that. So I think that's what's kind of unique about the shoulder when working with it, but ultimately it does break down to the same principles as any other joint in the body.
Mm-hmm.
All right, we'll pick up again next week.
Awesome. Looking forward to it.
All right. See you then.
See ya.